Thank you, Liz. Hi, I'm Victor Hartanto. Um, today we're going to have just like a talk about urinary incontinence, but this talk is more like informal, didactic type of presentation. I will breeze through my charts quickly, and then any questions and question and answer session afterward. I think that'll be more useful and it's good. All right, so I'm in Midland Park. Uh, Today we'll talk about incontinence, mainly the two major type of incontinence: stress and urinary incontinence. Um, More than 13 million Americans suffer from urinary incontinence. Majority of them are women. Also, men also obviously have incontinence for different various reasons as well. But majority of women. So what's incontinence? Incontinence is an intentional release of urine, unintentional release of urine. It could be embarrassing, unpredictable. People will start avoid active lifestyle, shy away, constantly search for a nearest bathroom, and also became too embarrassed to talk about it with the doctors. These are just cartoon illustration of what is urge and stress urinary incontinence. Urgency is actually urge incontinence is a urine loss accompanied by urgency resulting from abnormal bladder contraction. So basically, it's the muscle of the bladder itself, as opposed to stress incontinence is the urine loss resulting from sudden increase of the intra-abdominal pressure, which causes leakage, such as coughing, sneezing, or activities, jumping, and that's simply related to the sphincter muscle or the pucker muscle. So we know. Next, how do we diagnose that? First, let's start with the stress urinary incontinence. It is an involuntary or sudden loss of urine during physical activities such as laughing, sneezing, coughing, exercising. What can cause stress urinary incontinence? Normally in female with pelvic muscle strain, childbirth is the most common. Pelvic muscle tone loss, estrogen loss, being menopause. In men, generally after radical prostatectomy, there's some percentage of people with stress urinary incontinence. Stress incontinence is the most prevalent type of incontinence. More than 8 million women with stress incontinence affect women all ages, young mothers, doesn't matter, premenopause women, seniors. On average, it's 48 years old onset for women. It's a treatable condition. This is the treatment option. There's self-management, medication, biofeedback, bulking agents, and minimally invasive procedures. So I'll walk through this. Self-management is Kegel exercise. When we always heard Kegel, 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 and it's usually there's a use for that. And also pelvic muscle exercise. There are some actually pelvic floor physical therapists who could help patients with incontinence. Biofeedback is one a mean to kind of guide patients to how to exercise the muscle, sometimes pessary in less degree. This medications list is here, like alpha-1 agonists, like Sudafed, for example, or tricyclic antidepressant. but normally these medications are not the mainstay of treatment for stress incontinence. Bulking agents also, collagen, Durasvir, coaptide, generally for more, more like mild stress incontinence. So the mainstay of treatment for stress incontinence is the most successful treatment is a minimal invasive procedure, so-called TVT or TOT, which in general is called mid-urethral sling. In the past also there's bladder neck suspension, needle suspension. However, the gold standard treatment nowadays for stress incontinence is TVT or TOT. Now let's switch gear to overactive bladder or urgency incontinence. The prevalence of overactive bladder in the United States is more as people get older, men and women, as it's depicted in here in the graph, estimated to impact more than 33 million Americans with overactive bladder. Interestingly enough, overactive bladder is so common, and it's even more common than heart disease, asthma, bronchitis. The only thing that more common than overactive bladder is hypertension. Potential impact of overactive bladder on quality of life. As you see here, there are so many impacts, aspect in life. Physically, create limitation or cessation of physical activities, sexually, avoidance of sexual contact, absence of work, also constant looking for underwear, pull-ups, diapers, and also reduction of social interaction and limiting travel due to toilet accessibility. By definition, OAB or overactive bladder is a frequency of 8 or more visits to the toilet during waking hours, and waking up 2 or more at night to urinate. And urgency is a sudden, strong desire to urinate, sometimes followed by incontinence, involuntary loss of urine, or sometimes not incontinence. So how do you diagnose overactive bladder? I would say if I see patient with potential overactive bladder problem, history and physical and urine analysis. Those are the 3 main things. Even after the history taking, physical exam, and urine, I could probably 80%, 85% of the time tell that it is overactive bladder or not. So there is a study that will be helpful, but does not necessarily need to be done. It's called urodynamic study. So initiation of such as medication or stuff like that does not need to have it doesn't require extensive workup to begin with. So patient misconception of this overactive bladder is part of normal aging of everyday life, not severe or not frequent enough to treat, too embarrassing to discuss, and guess what? There's no treatment that can help. Those are the misconceptions out there. When we try to determine or delineate whether it is a overactive bladder or something else, we ought to focus on in the history, focus on the medical, neurological, and GU symptoms. Review voiding patterns, make sure the voiding diary was reviewed. Also, very important, medications are very important. Also evaluate functional and mental status. Sometimes you have some memory problem or whatnot that may also cause issue with the incontinence or overactive bladder. On physical exam, just general things, perform general abdominal examination. Neurologic exam is very important. Pelvic and rectal exam, and also make sure we watch if somebody coughing and sneezing and leaking. There's an important information. Urine analysis and also blood work is important to rule out if there is any blood in the urine or pus in the urine or bacteria or maybe sugar in the urine or protein. Those are all very helpful for evaluation. Now, to differentiate stress or overactive or urge urinary incontinence, normally, if you have a strong urgency or desire to urinate, it's more toward overactive bladder. Stress incontinence usually does not present that way. If you have a more frequency and urgency, like we mentioned before, 8 times more than waking hours, it's almost certain it's an overactive bladder and not stress. When you have leaking with physical activity, coughing, sneezing, lifting, that's more like stress incontinence because that's the weakness of the sphincter muscle. Is another important one here. When you notice a leakage coming, if it's like a large, like a flood, people say that's most likely is overactive bladder because stress incontinence usually is like a small squirt. And ability to reach the toilet in time usually is if you have that kind of urgency, meaning usually it's overactive rather than stress incontinence. And usually overactive bladder people wake up at night more often than stress incontinence patients. Treatment of overactive bladder, multiple facets of the treatment of overactive bladder. First level, we start with a behavior treatment, which is time voiding, delayed voiding, pelvic floor exercise, Kegel exercise, we call it. Also diet modification. Make sure that reduce the nighttime fluid before, like for example, after 7 or after 6 or whatnot, so you don't wake up at night to urinate. Because if you drink at night, you gotta wake up, because that's how you tell that your kidneys are functioning. So if you don't want to wake up at night, so we know for patient with bladder problem, we have to limit at night intake. Eliminate bladder irritants such as caffeine, alcohol, nicotine, and make sure there is no associated problem with bowel, because, for example, bowel constipation can also affect the urination. The next one is medication. Antibiotics, if it's a urinary tract infections, if we discover a UTI, we treat with antibiotics. Also topical estrogen for atrophic vaginitis. Mainstay of treatment for overactive bladder is anticholinergic and beta-3 agonist agents, such as all those medications that were on the market. So basically the overactive bladder symptoms, using those medications, it inhibits the involuntary bladder contraction and increased bladder capacity. So you would have a more bladder capacity and more flexible bladder. So when you got that urge, you can say, okay, let me take my time. I'm going to walk to the bathroom, and I can pee normally without the bladder dictating me. That's what the medication is for. Some also side effects of the medications, such as constipation, confusion, headache, slight elevation of blood pressure, dry mouth as well. Like I mentioned before, the medication stabilizing the detrusor muscle or the bladder muscle, which already overactive, so trying to relax it, and consequently, it will diminish the frequency and involuntary bladder contraction and increase the capacity. Then you'll have less frequency and better volume as you urinate. These are just the timeline availability of those medications and that I mentioned before, dated back in 1998. There was oxybutynin, even before that, dalteredine, and then the Detrol extended release, oxytrol patch, which is the oxybutynin extended release, and all this, Sanctura, Vesicare, Darafenacin. The latest one is Mirpatrix, the latest one, that was like 8 years ago. These are the side effects of the medications: dry mouth, constipation, blurred vision, tachycardia. These are all potential side effects. Doesn't necessarily mean that if two people taking the same medications, they will have exactly the same side effects. They typically will have a different side effects, for two different people taking the same medications. When you do, this is the success. When you take the antimuscarinic agent itself, it's less efficacious compared to if you take the medications plus the behavior therapy. Basically, both combination increase the success rate. These are just other next level. If those medications are not successful, meaning some of other level of treatments, including Botox injection, Interstim, which is the stimulator that is implanted in the backside, and also posterior tibial nerve stimulation like acupuncture. These are more extreme bladder denervation, and cystoplasty. It was a surgery, and eventually, if things are not working out, there's always catheter as a last resort. I think that's all my quickie. And if I'm gonna return it to Liz and back to you guys. Thank you.
Thanks, Dr. Hartanto. We do have a few questions, and I'd like to remind people, if they do have questions, to submit them in the Q&A area. The first one is, with bladder outlet obstruction, are there any new treatments besides Urethral?
Okay, a bladder, Uroxetrol. Okay. So Uroxetrol is one of the alpha-1 blocker agent. So basically, bladder outlet obstruction, Uroxetrol is to relax the muscle of the urethra and or prostate in men, and by doing that, it will open up the outlet, and it will make it easier for the urine to flow. Uroxetrol is one of the 4 medications out there that could be used for relaxing the muscle. There are more like Flomax. There are also Rapaflow. There's also doxycycline. Uroxetrol is actually 2 steps behind. The newest one is Rapaflow, which in a way it's stronger and more sensitive to urethra compared to Uroxetrol.
Great. Okay, there's also a request to repost chart 36, the list of prescription medications.
Okay.
Okay, and is it possible to have both issues, stress and, I'm trying to recall at the point in the slide or the point in the presentation, I think it was stress and urgency. Is it possible to have both?
Correct. As a matter of fact, I would say about 30% of people who presented have both combination of symptoms. And normally, when you have combination of those symptoms, if I ask, the most common people will say the urgency is more prominent than stress, because urgency you can't control. When you have these symptoms, you gotta go, and it's like out of your control. Otherwise, you're gonna be leaking. Stress incontinence, on the other hand, you could kind of like, okay, let me cross my leg and try to sneeze, before I sneeze, or maybe I can empty my bladder, more often and stuff, then it's more controllable. But also, the same token, there are also some people who really are so bothered by the stress incontinence. So then normally what I do, I first treat the stress, the urge incontinence. If it does not work, or it's not satisfying enough, then I also treat the stress incontinence as well. So there are some people who require both treatments.
Okay, someone has asked if you could address frequent urinary tract infections.
Okay, frequent urinary tract infections could be caused by, it depends on when you are in life. For example, young women, sexually active women, normally the most common cause of UTI is sexual intercourse. And once you enter the era of menopause, so from perimenopause on, normally the most common cause of UTI is what we call atrophic vaginitis. Atrophic vaginitis is basically a condition that is normal to all menopausal women. It's a condition that is lacking of estrogen. When you lack of estrogen, the pH in the vagina changes, and when it changes, when you have an estrogen still premenopause, the pH is acid in the vagina. Now, once you become a perimenopause and menopause, the pH rising in the vagina, and it causes the pH to be at a basic pH, and the basic pH environment is very favorable for bacteria to overgrow in the vagina, and then and as you know, the opening of the urethra is in the vagina, so the bacteria is coming up to the urethra and going up the bladder and cause infection. And the treatment for that is actually very easy. Atrophic vaginitis itself per se do not need to be treated because it's a normal condition. However, there are some indications that women needed to be treated because of the symptoms, such as recurrent urinary tract infections. Number 2, a severe pain with sexual intercourse. Number 3, vaginal bleeding. The treatment is easy. It's a topical estrogen. It's a really topical estrogen. It's a cream or a pill to the vagina, not by mouth. It's a topical estrogen. So those are the treatment options, and those are the most common cause of infection in postmenopausal women. In men, on the other hand, rarely happen urinary tract infections, but when it happens, the first thing that we need to focus on is the patient emptying the bladder. Normally, the most common cause of UTI in men is not emptying the bladder due to prostate enlargement. Then we treat the prostate, he empties the bladder, and then problem resolved.
That's a great segue into our next question. Can you discuss post-prostatectomy long-term incontinence?
Okay, so post-prostatectomy, I mean, prostatectomy is it's anatomy altering procedure. Obviously, men have two sphincters, as opposed to women who only has one sphincter. Men have two sphincters: external sphincter and internal sphincter. The external sphincter is what men and women both have, external sphincter. The internal sphincter is the prostate itself, is an internal sphincter. We cut out that prostate, that means you would have one less incontinence. And then, during the procedure, sometimes the muscle fibers of the external sphincter got severed and stuff, and then you get we have a post-prostatectomy incontinence. So basically, it ranges from less to severe incontinence. We normally started with like trying to do Kegel exercise even before the surgery was started, and also sometimes for the very mild incontinence, we can use also bulking agents. However, as the thing get progressively worsened, there's also male urethral sling that we can use, like the female one, sling, but in a male equivalent of it. And the most severe one is it's artificial urethral sphincter, the three-component one that you have a pump in the scrotum to pump.
Actually, another great segue regarding the sling. If someone had a sling procedure 25 years ago, is that something that needs to be redone? Is there a time limit on sling procedures?
Okay, the sling procedure is a procedure that does not really need to be repeated unless it's becoming for some reason, most of the time is the reason of getting older, the tissue getting more friable, and then it became more developing more incontinence. But normally it would not need to be repeated, because sling is a plastic thing. It's not degraded, is with time, so it's like when it stays. But sometimes stress incontinence can occur because we all getting older and we have a change in our body's tissues and stuff. Then we could repeat the sling. We could repeat the sling a second time, or even the third time.
Okay, so regarding aging, what are normal bladder changes with aging, or their general aspects of an aging bladder?
Okay, the normal aging the normal changes in the bladder normally is weakening of the contraction of the bladder. That's actually the most common is actually development of overactivity of the bladder, meaning as we age, the bladder becomes stiffer, like less flexible. Then it will lead to overactivity of the bladder, because that's what overactive bladder is: stiffer bladder and less flexible bladder.
Okay. Does a fixed bladder prolapse ever reoccur? If so, can it be fixed easily again?
Yes. Bladder prolapse, again, even though we fix the bladder prolapse first time, like now, and it becomes nice and fixed up there. But as we get older, everything gets weaker. you have less and less estrogen, less and less, a more lax muscle tone, and sometimes it, even though we were using mash in the repair, for example, sometimes because of the weakening of the thinning of the tissue, it rips through the mesh itself. So it's become recurring prolapse.
Okay. So someone was just adding something about prolapse surgery. The doctor used pig tissue. Does that have any effect on the length of?
No, it doesn't necessarily have any effect, because pig tissue also is a durable. It's known to be durable, but again, like the same token, the reason we don't use the own tissue, because the own tissue itself is so weak and already shredded. If you don't use any support to that shredded tissue, it will definitely recur much faster than it could be if you use some other thing. Although by using the mesh or pig tissue or bovine tissues, it can still recur.
Okay, so there's a question about Botox.
Mm-hmm.
And if someone were to, for a side effect of Botox, would that make you not be able to urinate at all, that you would need a catheter?
Correct. So this is what happened with Botox. Botox has a potential side effects. What we all fear of is urinary retention. Although, if we think about it, all those medications that is listed here, all of these medications have the same potential side effects as Botox, about 4 to 6%, 4 to 6% risk of urinary retention. However, these medications are short-acting medications. So if you have a retention with these medications, the retention will probably last about 2 to 3 days, as opposed to Botox. Botox is a long-acting medications. If you have retention, it will probably stay and linger for about 2 to 3 weeks. Now, retention is a definition, is a people's definition. Retention could mean that you are not able to urinate at all, or whatever is left inside the bladder, more than 200 cc's, for example, they can consider that retention. I mean, I've been giving Botox, so many of them, I have not seen a retention. I saw retention in one person. It's like 94-year-old gentleman. With retention that I need to put a catheter for about 3 weeks. And then after that, we remove the catheter and feed. But the rest of them are able to urinate well enough. For example, I always have my patient come back in 2 weeks, and then I'll scan the bladder. 0, 15, 20, sometimes 150. But I don't consider that retention, because the patient are still able to urinate, and patient feels like as if they're emptying the bladder, and the urine looks fine. There is no UTI, so that's fine. But some other institution or some other studies consider that 150 or 200 is urinary retention. So it does not necessarily mean that you can't pee. But if you can't pee, we could teach the patients how to catheterize themselves, or put a catheter for a couple of weeks and then take it out. And usually almost 100% of them are urinating.
Okay, besides quality of life issues, is there any detriment to your health for not treating urge incontinence?
No, not urge. Okay, first, for urgency incontinence could be treated like conservatively. For example, like, okay, I don't want to be treated. I don't want to take any medications, because any medications would have side effects. So I will reserve, with pull-ups, for example. That is a good way to treat as well. I mean, there is no you just make sure that you don't sit on the wet pull-ups for a long time, because it may cause infection. And but there is no detrimental effect in life as far as not treating it. Just make sure that if you don't treat it, you do something. For example, you don't wake up too many times at night to urinate. If you wear pull-ups at night, then you don't have to wake up. You just just pee in the pull-ups, and in the morning you just toss it.
Okay, we do have quite a few more questions, but I wanted to let people know that this is being recorded and it will be posted on the valleyhealth.com website, the recording. So for all the questions that are coming in about copies of the presentation, it will be available. So the next question was, do the topical or patch medications work as well for urgency as the oral medications?
Yes, actually, they are proven that the Oxytrol patch, or generic now, is working. It's working, and it's some people, although not all, some people claims that the side effects is minimized. That's what actually the purpose of the transdermal one. So it will reduce the side effects, but some people swear that that's just the same side effects as others.
Okay, there are a lot of questions about medications. One is, do the newer medications for urgency give a very dry mouth as the older ones did? And is there also a medication that might prolong someone to not have to get up to use the bathroom after being asleep for only 4 hours? They have to wake up to go to the bathroom. So is there medication that could help them sleep longer?
Right. So basically, all those medications. Let me answer the last one first. All those, the last one, yeah. All those medications, if it works, it should give you longer time to sleep, and also longer time in between urgency during the daytime. Those are the purpose of those medications, because just trying to relax the bladder, so it will give more volume in the bladder. So if you have more volume, that means you will hold more, you will have less frequency, and you will pee a lot more volume as you go. And going back to the earlier questions, all these medications, I can't really tell. I mean, all the potential side effects of all these medications are dry mouth, dry eyes, and constipation. The first 7 medications, and they all varies. They all varies with people. Somehow, some people, oxybutynin would be the first one came out in the market. Like the dinosaurs of everything is oxybutynin, and I tend to reserve the oxybutynin for the last one, because as promise of all other medications to follow that, when they came out, there will be less and less and less side effects. However, that is not completely true, because sometimes I start patient with Vesicare, for example, thinking that Vesicare is a newer medications would help less side effects. It did not work, and the side effects is terrible. And then I went back to oxybutynin, and people say, wow, this works very well. And so I can't really tell. I mean, I can't really tell how side effects affect people until people try. One thing that I should say is, after all those first 7 medications, we call anticholinergic medications, with all those side effects of dry mouth, constipation, blurry eyes, The next medication was manufactured, which is called Mirpatrix. That medication is the latest one and it's still not generic until now. And that medication is actually produced to combat all those side effects that the anticholinergic medications have. So normally it should not have dry mouth, dry eyes, constipation, and it can also use for all glaucoma patient. Mirpatrix has no contraindications of glaucoma. However, Mirpatrix also have their own side effects, as any medication is. It's like sometimes it potentially cause elevation of blood pressure. Not much, but sometimes, like 3 to 5 to 10. And, I have not stopped anybody taking Mirpatrix from high blood pressure. I mean, I take it back. There are 2 people that I did actually, because, the cardiologist showed that, the blood pressure is coming up. But people with hypertension on blood pressure medications, it has an advantage of taking Mirpatrix because they have been already on blood pressure medication.
How about with normal pressure hydrocephalus? Would the medications be effective for urinary urgency caused by that?
Correct. There's that's called neurogenic bladder hydrocephalus. The medications are pretty much the same. All those will respond well. I mean, not all of them, but we gotta try. We don't know which one is gonna respond, but those will respond to, yes.
Do you find that the medications that you prescribe are also supported by insurance companies? Like do you find that insurance companies cover? Okay.
Right. So that is something that I'm always confused, and I've been in practice this far, and I know oxybutynin until Mirpatrix right now. That is, normally even within Medicare itself, some Medicare would cover Mirpatrix, some of them are not. So some of them with a high deductible or high copay or co-insurance, and some of them are not. I cannot comment on that one because there are literally hundreds of insurance plans out there that have a different coverage for all this stuff.
Okay. Does the use of vaginal estrase cause stroke? How much estrase is acceptable to use?
Okay, so there are 3 absolute contraindications for using estrogen, topical estrogen. Number 1 is breast cancer. Even breast cancer is kind of soft now, especially if the breast cancer happens older than 5 years ago. We can even use that Uvavem or the Vagifem because they are actually made down, lowered down to 10 micrograms from 25 microgram to accommodate breast cancer patient. Number 2 contraindication is stroke patient. Number 3, blood clots patient. So yes, that's a contraindication for stroke patient. Although some of the neurologists also mentioned that you could sometimes use it with the lower dose cream. I mean, lower dose vaginal pill or Vagifem or Uvavem.
Okay, we have 2 questions related to, and I apologize for the pronunciation, interstitial cystitis. One is, are there new meds for it? And the other is the difference. What's the difference between that and overactive bladder?
Correct. So interstitial cystitis is a condition that none of us like. I certainly do not like interstitial cystitis because it's hard for the patient and it's hard for me to treat. There's however, if you respond to medications. The interstitial cystitis could be dormant and could be treated. It could be, happily treated for patients. There are no new medications for it. It's the Elmeron is the oral and all this bladder installations. There's nothing new in the horizon. And basically, how would you differentiate between overactive bladder and interstitial cystitis? Overactive bladder is a pathologic condition, as well as IC. IC normally comes with like more severe bladder pain, not urgency and frequency and leakage, but more pain. That's why it's called bladder pain syndrome. And normally, if you are having, interstitial cystitis is actually a diagnosis of exclusion. There are so stringent criteria in order for diagnosis of interstitial cystitis. There, you cannot have any active UTI. You cannot have any other pathology in the bladder, such as overactive bladder, like a urinary retention, and all this stuff. So to differentiate, it's kind of difficult. But for example, if you have a accessibility to do urodynamic study, for example, we will definitely be able to differentiate if it is an overactive bladder or something else that, unexplained so-called interstitial cystitis.
If you have narrow channel glaucoma, is it dangerous to use oxytrol patch or the gel?
Correct. You cannot use any one of those anticholinergic medications if you have narrow or close angle glaucoma.
Okay, and how long do you need to stay on a medication such as Mirpatrix?
I would say forever, but there's nothing forever, right? These medications is like overactive. Okay, so overactive bladder is actually controllable condition, but not curable condition. So it's like blood pressure. If you take blood pressure medications, your blood pressure is controlled. If you don't want to take it, that's fine. But the result of it, that your blood pressure will not be controlled. The same thing as this overactive bladder. Overactive bladder is a condition that is controllable. If you are fine with whatever you have now, who am I to say that you have to take medications to treat it or treat it with something else? But if you are taking the medication, you can take the medications and it controls the situation. And then you say to yourself, I'm sick and tired of taking medications. It's like, I'm taking 3 too many medications, so let me just stop it. Nothing is going to happen except your symptoms is going to return. But other things, your heart is not going to be affected by stopping anticholinergic medications or Mirpatrix or anything like that. It's just your symptoms return.
Okay, and what does bulking involve?
Bulking agent involve doing cystoscopy and injected those bulking agents around the bladder neck to kind of bulk the mucosa, so it will close up the bladder neck, so it helps the incontinence.
Okay, that's actually all of our questions. Thank you so much, Dr. Hartanto, for your informative presentation. At this time, I'd like to remind everyone at home